So first, let's talk a little bit about nociceptors and the different types we are dealing with during and after a muscle strain. Now, before moving on, I want to make sure you are all familiar with basic terminology. When I say neuron or nerve fiber, I'm referring to the same thing. These are nerve cells which make up nerve tissue. So nerve fibers slash neurons are essentially projections from nerves that innervate various tissues in the body. This is why nerve fibers slash neurons are also referred to as nerve endings. So nerve fibers, neurons, nerve endings are synonymous terms. I wanted to clear that up so you are not all confused due to terminology. The nerve fibers we are discussing here are part of the sensory nervous system, so they are afferent nerve fibers. Afferent, again, describes sensory information going from the body's periphery, like muscle and skin, for example, towards the central nervous system, the spinal cord and the brain. This sensory and thus afferent information is in the form of neuroelectrical signals called action potentials, which you can think of simply as a wave of depolarization or simply activation of the neuron. All right, so let's break down these afferent slash sensory nerve fibers into a specific category called nociceptors. To reiterate, nociceptors are sensory neurons that respond to noxious stimuli in the periphery, like around a rupture site of a muscle. And nociceptors are responsible for informing the CNS, the central nervous system, that there is a high presence of a certain noxious stimuli, whether it's in chemical, thermal, or mechanical form. And these signals are quote-unquote threat signals, and thus, when the CNS perceives these threat signals as credible, it will generate the perception of pain. This whole process is described as nociception. And always keep in mind that nociceptors have a certain stimulation slash activation threshold. That is, they require a minimum level of stimulation and thus minimum level of noxious stimuli before the nociceptors can trigger an afferent signal towards the CNS. And as I mentioned earlier, there are a variety of noxious stimuli, and we all should know generally what they are in nature because we generally know what causes pain. We know that touch, pressure, stretch, tension can cause pain, and that is described as mechanical stimuli. We know heat and cold can cause pain, and that is described as thermostimuli. And what is less known but introduced earlier with regards to inflammation is that certain chemicals within the body can cause pain, and this is referred to as chemical stimuli. Okay, now let's break down nociceptors and different major types that we are dealing with when it comes to muscle strains and even EIMD. In this figure, we have two types of nociceptors, which are two major types within the human body, and they're highly implicated in post-muscle injury pain situations. They both share similarities, but also have distinct differences. The two types of nociceptor nerve fibers, as illustrated here, are the type 3 and type 4 nerve fibers, which are again, obviously, sensory neurons. They are afferent neurons. Type 3 nerve fibers are also classified as group A delta fibers, and type 4 fibers are also classified as group C nerve fibers. These are your two main nociceptors. Some type 2 sensory nerve fibers are also nociceptors, but they function mainly as mechanoreceptors, especially in muscle and also underneath your skin, to detect things like length changes in the muscle, pressure on the skin, or contact on the skin. But for now, let's not talk about type 2 nerve fibers and focus on types 3 and 4 since these nerve fibers are primarily involved in the nociception post-muscle strain. So one common characteristic between these two nerve fibers is that at the peripheral end, so the end opposite of the central nervous system, these nerve fibers represent free nerve endings, which look something like tree roots as depicted up here. This is at the periphery, say around muscle tissue. Free nerve endings, like the type 3s and 4s as shown here, are nerve fibers that do not innervate some sort of sensory organ, like the group 1B neurons that innervate the GTO, which is the sensory organ. Another example of a non-free nerve ending is the group 1A neuron, which innervates the sensory organ, the muscle spindles, inside skeletal muscle. So types 3 and 4 sensory nerve fibers are free nerve endings, and at the ends of these nerve fiber branches, also known as the axon terminal, we have all kinds of different receptors that respond to various noxious stimuli. So on each of these axon terminals here, at the ends of the tree root, There are a number of receptors that are expressed at the end of the axon terminal. So let's discuss each of these two nociceptors, including their differences and how they are involved in the pain experienced during and following a muscle strain. First, we have the type 3/group A delta nerve fiber, which again mainly function as a nociceptor. These are not the largest diameter nerve fibers, but larger than the type 4s. They have a diameter of 2 to 5 micrometers, or microns. Type 3 nerve fibers have a comparatively low stimulation threshold. In other words, they are highly excitable. This means that when compared to type 4s, they do not require a relatively high amount of noxious stimuli to be triggered, that is, to depolarize and transmit action potentials towards the CNS. Another way you can think of it is that type 3s are more sensitive to noxious stimuli versus type 4s. In addition, type 3s, once they are activated and action potentials are generated, the neuroelectrical signal propagates or travels towards the CNS at a rate faster than the type 4s. Among all the types of neurons, however, we can consider the conduction speed of type 3 afferents as moderate, which is about 5 to 40 meters per second. This means that once the noxious stimuli activates these type 3 sensory nerve fibers, that signal travels relatively fast to the CNS. This is one of the reasons as to why type 3 sensory neurons are responsible for sharp, immediate pain. In the next slide, we will discuss how this applies to a muscle strain situation. Another example, however, just for you to visualize, is when you touch something really sharp, like a knife point. That sharp immediate pain was derived from the activation and the fast propagation of nociceptive signals by the type 3 sensory neurons. They are very responsive. Now, one of the major factors that contribute to this conduction speed is myelination. If you remember from your basic physiology course, nerve fibers that have myelinated axons, as you see here, have much more efficient signal propagation. And this is because the myelin sheaths preserve the action potential as it travels through the axon towards the central nervous system. Another key point is that the type 3 nociceptors have a small receptive field, meaning the ends of these nerve fibers, which contain the different receptors, only cover a small area. This means that when you feel that pain, you know exactly where that pain is coming from. Let's go ahead and use that sharp knife point example to help explain this concept. When we touch that sharp knife point, we not only experience the pain immediately and sharply, but we know exactly where on our body the noxious stimuli is located, and thus where that nociceptive signal came from. This is why when we feel that sharp pain after touching a sharp object, we know exactly where to direct our attention to. The smaller receptive field allows for a more precise location of the pain source. And finally, type 3 sensory neurons are responsive to two major classes of stimuli, and that is mechanical and thermal, particularly cold. So on the ends of these type 3 fibers at its axon terminals, you have receptors that respond to mechanical and thermal stimuli. To reiterate an example of mechanical stimuli, this can come in the form of touch, pressure, stretch, or tension. We are talking about physical perturbation of the tissue of which the type 3 neuron is associated with. For example, when you stretch your muscle, you perceive that sense of stretch. This is a non-noxious mechanical stimuli. But as the stretch intensifies, so does the mechanical stimuli. And when the nociceptor hits a certain stimulation threshold, that mechanical stimuli from the stretch will become noxious and trigger the type 3 nociceptors. At this point, we stop stretching the muscle because it hurts too much. The same concept applies to thermal stimuli. And in the case of type 3 neurons, it is much more responsive to cold stimuli. So say you put your hand in cold water, you sense the cold. Then you decrease the temperature of the water and that cold thermal stimuli starts to intensify. When the temperature is lowered to a point when the cold stimuli exceeds a certain stimulation threshold of these nociceptors, that cold thermal stimuli becomes noxious and the type 3 neurons are triggered. At this point, it will hurt to put your hand in that water because it is quote unquote too cold. So please keep these examples in mind as we move forward because they have huge implications not only to the pain we feel during a strain, but also to the management of pain. But before we get to that, let's look at the type 4 nerve fibers, more commonly referred to as the group C nerve fibers. So these nerve fibers are smaller in diameter versus the type 3 and has a diameter of about 0.4 to 1.2 microns or micrometers. But more importantly, type 4 nerve fibers are not as excitable as the type 3. Remember, excitability is referring to the threshold by which the nerve fiber is activated. So with lower excitability, you have a higher stimulation threshold, meaning there is a need for a relatively large amount of noxious stimuli and thus stimulation to trigger these type 4 neurons. Furthermore, these nerve fibers are described as slow in that their conduction velocity is the slowest of all sensory neuron types. And the major reason for that is because it is the only sensory neuron that is unmyelinated. They do not contain myelin sheets around its axon. Therefore, these neurons have less efficiency in action potential propagation. In simple terms, the signal has a tougher time traveling from its periphery towards the central nervous system, and thus these signals are received at the CNS at a slower rate, and this is compared to the type 3 and all other sensory neurons. So how does this low level of excitability and thus high stimulation threshold as well as slow conduction speed manifest itself? Well, with type 3s, the lower stimulation threshold and faster conduction speed of the nociceptive signals contribute to the perception of immediate and sharp pain, as we discussed earlier. So with type 4, the lower excitability and slower conduction speed contributes to dull throbbing pain, as opposed to sharp immediate pain. And the perception of this dull pain is less precise when it comes to the exact location of the stimuli. It is much broader, in other words. This is due to a large receptive field for the type 4 neurons. The nerve endings of the type 4 cover a comparatively larger area surrounding a particular tissue. Thus, the location of noxious stimuli is less precise. Now, at this point, I'm guessing you might be able to identify where the type 4 nerve fibers play a role in the pain we experience following a strain, but we will discuss that in detail in the next slide. However, just to provide some practical examples for now, let's use the sharp knife point example again. So as we said, when you touch the point of a sharp knife and you puncture your skin, you will feel that sharp immediate pain. This is due to the type 3 sensory neurons. Then later that day and for a few days later, that wound is associated with a different type of pain. It's not sharp or immediate, it is dull and throbbing pain. This is due to some other noxious stimuli that is triggering the type 4 sensory neurons. Perhaps I'm alluding to chemicals associated with inflammation following the puncture. Now here's something to keep you thinking forward a bit. In this situation, as you experience full throbbing pain due to stimulation of type 4 neurons, say you accidentally made light contact with that puncture wound. Normally, that light contact when there is no puncture wound wouldn't cause any pain. But in this case, you felt sharp immediate pain. Why do you think that is? Why is that area surrounding the wound much more sensitive to mechanical stimuli? Well, it appears that the type 3 neurons are much more sensitive to mechanical stimuli. In other words, it has a lower stimulation threshold now. And thus, even with light contact that normally would not cause pain, you get sharp immediate pain at that wound site. So I wanted to add this little detail to our example here to get you thinking a bit as we move forward and discuss how all this applies to a muscle strain situation. Now, as for some other details regarding type 4 sensory neurons, these sensory neurons are highly polymodal. This means that they respond to a variety of stimuli, and this is because their nerve ending branches express a variety of receptors that respond to mechanical, thermal, and chemical stimuli. And with that said, a majority of the nociceptors in our body are type 4/group C nerve fibers. Now, just to clarify some details in this figure, DRG stands for dorsal root ganglion, which is part of a larger spinal nerve. This is where multiple neurons from the periphery integrate into. The dorsal root ganglion houses the cell body of all sensory neurons integrating at this given spinal nerve. So that is what we see here. And later I will show you another depiction of this to help you better visualize the sensory neuron. But please keep in mind, this is not a very important detail within the context of what we're discussing. So now let's talk about these nociceptors within the context of a muscle strain. And let's remember the sharp knife example I provided a few moments ago to help you understand the roles of these nociceptors during and following a muscle strain. All right, first, what types of noxious stimuli are we dealing with here? We are dealing with both mechanical and chemical noxious stimuli, as we have discussed thus far. First, mechanical noxious stimuli. The initial mechanical noxious stimuli associated with a muscle strain is involved during the actual strain moment where the muscle undergoes a tear or rupture. The rupturing of the muscle in itself is a mechanical stimulus, and it is a very high mechanical stimulus. This is comparable to the mechanical noxious stimulus when you puncture your finger upon making contact with the sharp knife point. We know that this mechanical noxious stimulus is going to manifest in sharp immediate pain. So this sharp immediate pain that you experience upon rupturing your muscle is due to the type 3 sensory nerve fibers responding to the mechanical stimuli afforded through the tearing of the tissue. Once again, to explain this from a physiological standpoint, you experience sharp and immediate pain because 1. Type 3 nerve fiber stimulation threshold is low and thus are more sensitive to noxious stimuli, and 2. The conduction velocity of the nociceptive signal towards the CNS is fast due to the myelination of the axon. We also know precisely where the rupture took place. We know what muscle and what specific area of the muscle has torn almost immediately because the type 3s have a small receptive field. This means we can precisely locate the origin of that mechanical stimuli and thus the location of the injury right upon the rupture moment. Now, what about the chemical noxious stimuli and how do they play a role in the pain that is experienced following a muscle strain? We obviously discussed this to some extent earlier, but just so that you are clear on the physiological mechanism, let's discuss chemical noxious stimuli a bit further. First, we have some chemicals as well as ions that are leaked from damaged muscle fibers. This primarily includes ATP, adenosine triphosphate, which as most of you know is the cell's energy currency, and potassium, which is also highly concentrated within the cell. And please remember in this case, the potassium is a positively charged ion. Then we also have positively charged hydrogen ions, which are simply referred to as a proton, since it is made up of a single proton and no electrons. An accumulation of protons in any solution would increase the acidity of said solution, and thus reducing the solution's pH. This is a situation described as acidosis. Acidosis is a well-known chemical noxious stimuli and is responsible for much of the burning muscle pain we feel when we perform high-intensity exercise, like when we lift weights or when muscles become underperfused, which means poor blood supply. Acidosis occurs in muscle when the rate of oxygen availability does not meet the rate of oxygen demand. This occurs in those two scenarios described above in muscle: high-intensity exercise, where there's a high rate of oxygen need, and also underperfusion when there is a low rate of oxygen delivery. Altogether, those two situations reflect a situation in which the rate of oxygen availability does not meet the rate of oxygen demand. During a muscle strain situation, there is not only a leakage of protons from the damaged cells, but there is also underperfusion of the muscle cells around the ruptured area, and this is due to the damaged micro blood vessels surrounding the muscle. This would in turn impair the oxygen delivery and thus availability for the muscle cells around the rupture site. As a result, there will be a greater accumulation of protons and thus acidosis. On the ends of the nociceptors, particularly the type 4 group C nerve fibers, there are specialized receptors called acid sensing ion channels, or ASICs for short. These receptor channels respond to high levels of protons and thus acidosis. When there is a high level of protons present, there is a high level of binding between protons and these acid-sensing ion channels. This causes the channel to open, allowing positively charged ions to influx into the end of the nerve fiber, causing the neuron to depolarize and thus generate action potentials, which, as we know, propagate towards the CNS. And as we described earlier, this signal would travel relatively slow via the type 4 nerve fibers and is associated with a dull, throbbing type pain sensation. This dull pain is often described as muscle soreness. And if you can imagine, this dull pain lingers on. It's not immediate like with the pain elicited by the type 3 neurons. This is because there is a slow but perpetual propagation of nociceptive signals through the type 4 nerve fibers. So one major chemical noxious stimuli following a muscle strain that is partly responsible for soreness or dull pain are protons/acidosis. They trigger the type 4 nerve fibers through the acid-sensing ion channels, the ASICs. And again, these are expressed at the peripheral end of the sensory neuron, at its axon terminal. So what other chemical noxious stimuli are present following a muscle strain? We mentioned earlier inflammatory chemicals, in other words, chemicals that are released by inflammatory/immune cells, as well as damaged muscle cells. And this is all during the acute inflammation period following an injury. Here below we have a list of prominent inflammatory chemicals that are released during the acute inflammation period. And of course, you should understand that their primary roles are to mediate inflammation and eventually initiate the healing process. You have to understand that all the individual processes following injury all the way to repair involves signals, and these signals are afforded through these chemicals/molecules. In our first lecture series, we only talked about a few signaling molecules or chemicals because the focus was rather on understanding the general process as opposed to covering each individual signaling pathway mediated by these individual chemicals. So here we have some of the main ones. We got tumor necrosis factor alpha or TNF alpha, interleukin 1 beta and interleukin 6, bradykinin, prostaglandin E2 and F2, and free radicals, more specifically reactive oxygen species. All these chemicals/molecules again play an important role in mediating the entire acute inflammatory process leading into healing. However, they are also stimuli for pain. They are all noxious stimuli when their levels exceed the stimulation threshold for nociceptors, particularly the type 4s, which again are more responsive to chemical noxious stimuli than the type 3s. Of these, the two most prominent ones and most implicated in pain management modalities, particularly drug modalities, include the prostaglandins, as highlighted in red font. And the reason they are highlighted in red font is because we're going to discuss these two further later on, as they are the two major targets for non-steroidal and steroidal anti-inflammatory analgesics. Now, most chemical noxious stimuli trigger nociceptors like the type 4 through Trp channels, which stand for Transient Receptor Potential Channels, as well as GPCRs, which stand for G protein coupled receptor. And these are highly expressed on the terminal ends of the type 4 nociceptors. And these channels respond to elevated levels of some of these chemicals, particularly the prostaglandins. So let me zoom in on the terminal ends of a nociceptor and show you generally what is going on. As you can see, you have inflammatory immune cells and damaged tissue releasing a host of different chemicals. We have some here that we discussed like ATP, protons, prostaglandins, bradykinin, TNF alpha, interleukins, and we have some minor ones that I didn't mention. And when these accumulate in high amounts, these receptors on the ends of the nociceptors called the axon terminal, they respond, causing a depolarization of the nociceptor or activation of the nociceptor. This is when the nociceptive signal that goes towards the CNS is generated. Here we see the TRPs and the GPCRs, as well as the ASICs right here. There are other receptors as well, but for the sake of simplicity, we'll just focus on the major ones implicated during muscle strain situations. Next, I also mentioned that the location of the pain/soreness is less precise than the pain experienced immediately upon the tear. In other words, the soreness spans a broader area of the muscle. This is again because a larger receptive field for the type 4 nerve fibers. And thus, oftentimes, following an injury, it feels as though the entire muscle is sore, even though a smaller specific area of the muscle has undergone a tear. Finally, as I emphasized earlier, that in addition to soreness, there's increased sensitivity to mechanical stress, like when you stretch, contract, or make contact with the injured muscle. I mentioned that this is generally described as tenderness, but more technically referred to as hyperalgesia. And hyperalgesia is what specifically limits muscle function because it hurts to use the muscle. Fundamentally, as I said, this is for the sake of protecting the muscle through a biological feedback mechanism. It is protecting the muscle from more tension. So the question is, what causes this hyperalgesia in the injured muscle? What causes the injured muscle to be much more sensitive to mechanical stimuli in terms of nociception? This has a lot to do with chemical noxious stimuli. So there is a receptor on both the type 3 and 4 nociceptors that respond to both chemical and mechanical stimuli. That is the Trp channels. So because of the chemical noxious stimuli, these Trp channels are very responsive and thus active. What else is happening is that these Trp channels become hypersensitive in that their stimulation threshold is lowered. This means that they can be activated in response to lower levels of stimulation, particularly mechanical stimulation. This is why there is immediate pain even with just light use or mechanical perturbation of the strained muscle. So a level of mechanical stimuli that does not normally elicit pain now elicits pain. And again, from a biological perspective, this should all make sense as to why it happens. Hyperalgesia of the injured muscle is again to protect the muscle from mechanical stress, like tension, that would cause further damage. So just imagine during acute inflammation, when there is elevation of chemical noxious stimuli, the Trp channels, which again respond to both mechanical and chemical stimuli, become more sensitive and thus have a lowered stimulation threshold. Now, in more severe cases with large levels of acute inflammation, nociceptors that are normally dormant essentially come alive, quote unquote. These dormant nociceptors are called silent nociceptors, and they are triggered only in situations when there is an excess level of noxious stimuli present, again, such as during a severe high-grade strain. Also, non-nociceptive sensory neurons like type 2 sensory neurons can become nociceptive as well. Type 2 are normally mechanoreceptors that simply provide signals to perceive mechanical changes in the muscle and the subcutaneous space underneath the skin. For example, they are touch sensors. However, during excessive acute inflammation, they can become nociceptive. So altogether, these are the mechanisms underlying the hyperalgesia or tenderness following a muscle strain, and explains why sore/injured muscles are much more sensitive to mechanical stress. Now, just for the purpose of providing you with a more detailed perspective of the mechanisms underlying nociception and hyperalgesia, here we have a very comprehensive figure of the entire pathway, from the noxious stimuli to the propagation of nociceptive signals to the perception of pain in the CNS. The main purpose is for you to understand the complexity of the process and also to understand the targets along this entire pathway that can be manipulated for the sake of pain management/analgesia. So let's take a look at the beginning of the nociceptive pathway, which is illustrated here in box A. This is the end of one of those nociceptor sensory neurons, aka the axon terminal. Remember, these nociceptors are free nerve endings, so they do not innervate any particular sensory organ. The axon terminal, as I mentioned, expresses a variety of different receptors/channels that respond to specific noxious stimuli. If you zoom in on your slide, you will be able to identify some of the major noxious stimuli that I mentioned earlier and are associated with muscle strains. And also, if you look closely, you will be able to see a variety of receptors. You will see the Trp channels, the GPCR channels, and the ASICs. And these are the three that I mentioned earlier. But also, you will see thermoreceptors that respond to cold and heat as well. Now, just to hint at a topic we will discuss shortly, if you zoom in, you can see that the receptor that responds to cold are Trp channels as well, which, as I mentioned, also respond to mechanical and chemical stimuli, which are the two stimuli that triggers nociception following a muscle injury. So this sort of alludes how cryotherapy may somehow, quote unquote, compete with chemical and mechanical stimuli and perhaps disrupt nociceptive signals derived from chemical and mechanical noxious stimuli. So more on that later. But for now, just know that we have a host of noxious stimuli and a host of relevant receptors that respond to these noxious stimuli. And remember, each of these receptors have a stimulation threshold, meaning they must be stimulated by the noxious stimuli to a minimum degree to trigger an action potential signal in the nociceptor. So let's take a TRP channel, for example. The TRP channels are either calcium or sodium ion channels, specifically positively charged calcium and sodium ions. When the TRP is stimulated by a mechanical or chemical noxious stimuli, they open and allow sodium or calcium influx into the neuron. Because these are positively charged ions, their influx will increase the membrane potential at the axon terminal. The membrane potential, if you remember from basic physiology, is generally the electrical charge of the cell. So when the membrane potential increases, that is called depolarization. The neuron at the axon terminal will depolarize until it reaches a particular voltage at which an action potential is generated. This action potential is the neuroelectrical signal that will propagate in the afferent direction towards the CNS. Now, as the signal travels through the nerve fiber to the spinal cord, it will synapse with the spinal nerve cell. And here, the action potential will activate a complex pathway of reactions and signaling that will eventually result in the release of neurotransmitters into this synaptic cleft in the space between the nociceptor and the postsynaptic spinal neuron. These neurotransmitters will then interact with their own receptors on the postsynaptic spinal neuron, which will in turn cause the neuron to produce a nerve signal. This signal then proceeds to the brain, where it is further processed. And if the brain perceives this signal as a sign of credible threat, it will produce the perception of pain. So the reason I wanted to generally break down this entire pathway of nociception is because, again, the targets of pain management interventions are at different spots along this entire pathway. If you think about it, if you could somehow block the signal from reaching the brain, you would decrease the perception of pain because the perception of pain relies solely on the signal reaching the brain. So without going into details yet, think about where along this entire pathway would be the target of pain management modalities. Could you reduce or neutralize the noxious stimuli? Could you block or disrupt or inhibit chemical or mechanical receptors on the nociceptor axon terminal? Could you block the release of neurotransmitters from the nociceptor and thus block the communication between the nociceptor and the postsynaptic spinal neuron? The simple answer to all these questions are yes. There are non-pharmacological and pharmacological analgesics that target one or two of the potential areas along this entire pathway. For example, synthetic opioids like Oxycontin, Vicodin, morphine, and codeine target two areas of this pathway. First, they target the nociceptor at the periphery at the axon terminal. On the nociceptor's axon terminal, there's a receptor called the opioid receptor, which is indicated here by the cursor. When the opioid receptor is bound to an opioid, there is a series of signaling processes inside the axon terminal that eventually block calcium influx, which I indicated earlier is responsible for depolarizing and thus activating the nociceptor. So if depolarization of this neuron is inhibited due to the activated opioid receptor, then obviously no or less nociceptive signals will reach the CNS. In so doing, none of the processes following the activation of the nociception would occur, like the release of neurotransmitters here and the activation of the spinal neuron. In addition, and partly contributing to the potency of synthetic opioids, is that opioid receptors are also expressed up here on the other end of the nociceptor. When the opioid receptor here is bound to an opioid, these receptors will again inhibit calcium influx, which in this part of the pathway calcium influx would stimulate the release of neurotransmitters. So opioids, when they bind to the opioid receptor on this part of the pathway, it will inhibit the release of neurotransmitters. And in so doing, it will block the communication between the nociceptor and the spinal neuron. So the signal will never reach the brain. So in summary, as you can see, opioids disrupt nociception in two areas through its receptor, which again inhibits calcium influx, here as well as here. Here, the inhibition of calcium influx would inhibit depolarization of the nociceptor. And here, the inhibition of calcium influx would inhibit neurotransmitter release and thus communication with the upper spinal nerve. This is why opioids are very potent analgesics and sometimes used for anesthesia. Now, keep in mind, our body does produce its own endogenous opioids, which include endorphins. And endorphins are naturally released in response to injury, which helps modulate pain, but oftentimes it's not enough to totally mitigate pain. And from a biological perspective, it wouldn't make sense for your own body to inhibit nociception completely to the point it eradicates the perception of pain, because again, pain is a necessary feedback mechanism to protect the injured tissue. So your natural opioids are intended to only modulate nociception, not to totally eradicate it. Also, an interesting fact for you is that cannabinoid receptors are also expressed on the nociceptor here as well as here. And they function very similarly as opioid receptors in terms of its mechanism of action. Cannabinoids like THC and CBD can stimulate these cannabinoid receptors and may have similar but not as potent analgesic effects like opioids. This is why some resort to cannabinoid ointments or some form of cannabinoid administration for pain relief as an alternative to opioids. Its potency again is not as high as synthetic opioids, and thus its efficacy in terms of analgesia remains debatable and not entirely substantiated by scientific evidence. However, the mechanism of action is definitely well substantiated and again is similar to that of the opioid receptor. Now, as I said, the reason I am presenting this slide is for you to understand the general pathway by which nociception occurs following an injury. But let's go ahead and simplify it a bit more to help us better visualize where the targets of intervention are along this nociceptive pathway for analgesic modalities that again include non-pharmacological and pharmacological approaches. Alright, so here we have a way more simplified version of this nociceptive pathway. And in this figure, we have this pathway in relation to muscle strains. So to reiterate, after a strain, there is an acute inflammation response that involves the release of inflammatory chemicals as well as free radicals. In addition to this, we have accumulation of protons and thus acidosis, plus positively charged potassium ions and ATP leaked from damaged muscle cells. All of these are chemical noxious stimuli, which stimulate respective receptors on the nociceptors at the axon terminal. When the stimulation of these receptors reach a determined threshold, the nociceptor depolarizes and action potentials are generated as represented by this lightning bolt figure. The action potentials, which reflect the nociceptive signal, propagates in the afferent direction towards the CNS. At the spinal cord, the nociceptors synapse with spinal neurons. It communicates with the spinal neurons through neurotransmitters, which are released by the nociceptor when the action potential arrives. The neurotransmitters then bind to its receptors on the spinal neuron and depolarizes it, and thus activates the spinal neuron and projecting that signal towards the brain, where the signals are encoded and pain is perceived. And again, this pain is to protect your muscle from unnecessary overload stress in the form of tension. All right, so in order to experience pain relief or analgesia, we need to disrupt or inhibit this nociceptive signal along this entire pathway. We talked a little bit about how opioids do that by inhibiting the release of neurotransmitters by the nociceptors here in the spinal cord to block communication with the spinal neuron. And we also talked about how opioids can also inhibit depolarization of the nociceptive here, and thus decrease nociceptive signal propagation towards the CNS. So, what are the common targets along this pathway for pain relief through more traditional analgesics other than opioids? Altogether, the common targets are usually upstream of the CNS, meaning common analgesic targets on this nociceptive pathway are processes before the signal gets to the CNS, more specifically, the spinal neurons. So as you can see by this figure, there are two major analgesic targets along this nociceptive pathway. One of the targets are the chemical noxious stimuli that are responsible for hyperalgesia as well as soreness. Since the chemical noxious stimuli are released during the acute inflammation, the analgesic approach will be to reduce inflammation. We collectively refer to these analgesics as anti-inflammatory analgesics. Along with inflammatory chemicals, we also have free radicals that are also released during inflammation. And thus, along with anti-inflammatories, we also have antioxidants, which are molecules intended to neutralize free radicals. So to summarize, we have anti-inflammatories plus antioxidants to reduce or inhibit chemical noxious stimuli. This in turn will clearly reduce nociceptive signals through this mechanism. Now, just to add as a side note, antioxidants have not shown to be very potent in terms of its analgesic effects. And this is in comparison to modalities that intend to reduce inflammatory chemicals. Now, the other target is the nociceptive signal itself. There are analgesic modalities that are intended to disrupt the afferent nociceptive signal by acting on the nociceptor. And this is commonly just described as nociceptive signal disruption or inhibition. Okay, so to summarize, the targets for common pain relief or analgesic modalities are upstream of the central nervous system and target the inflammatory chemicals through anti-inflammation, as well as the nociceptor itself through nociceptive signal disruption. So with that said, we can compartmentalize the common analgesics for pain management following a muscle injury by its targets along the nociceptive pathway. On the left, we have examples of analgesics that target the nociceptor and are intended to disrupt or block the nociceptive signal from reaching the CNS, or more specifically, the brain. On the right, we have examples of analgesics that target the noxious stimuli itself associated with the acute inflammation following the injury. These are mostly anti-inflammatories and to a lesser extent antioxidants. I didn't list any antioxidants here mainly because there is no substantial evidence to suggest that antioxidants exert even a partial analgesic effect, but technically from a mechanistic standpoint it can, since free radicals are a known noxious stimuli. The question therefore is, are antioxidants, especially introduced through the diet, potent enough to have a significant antioxidant effect to neutralize free radicals at an injury site to the point where pain is averted? At this point, the general consensus in the scientific community is not really. Therefore, I did not include any antioxidants here under this category of analgesics. So on the nociceptive neuron or signal inhibition category of analgesics, here we have some of the common ones. We got transcutaneous nerve stimulation, manual therapies like massage or quote-unquote myofascial release techniques. Other manual therapies may include instrument-assisted soft tissue mobilization or scraping, and even the use of percussive therapy like with a Theragun, for example. We also have cryotherapy, both localized like with icing or whole body like with ice or cold baths and cryochambers. Lastly, we have topical quote-unquote cooling ointments, which for the most part contain a chemical called menthol. More on that later. All of these analgesics and most of those that target the disruption of nociceptive signal and nociceptors work through a mechanism titled the gate control theory of pain. The only exceptions are those that provide some sort of thermal stimuli like cryotherapy and cooling ointments. These work through a mechanism different than what is described by the gate control theory. We will discuss, of course, these mechanisms shortly. On the other side, we have anti-inflammatory analgesics that serve to reduce the amount of chemical noxious stimuli, mainly inflammatory chemicals like prostaglandins, which we highlighted in red in a couple slides back. Many of these include anti-inflammatory drugs, both non-steroidal like ibuprofen, aspirin, and naproxen, and steroid types like corticosteroids, often referred to simply as steroids. Cryotherapy, as I hinted earlier, also falls under this category, but as I mentioned before, it only exerts a minimal anti-inflammatory effect, but is an effective analgesic primarily through this target on the left, and not so much through anti-inflammatory effects. So let's go ahead and discuss the proposed mechanisms through which these analgesics work to reduce pain or hyperalgesia. First, we will start with analgesics that target nociceptive signal disruption, followed by those that target inflammation and related chemical noxious stimuli. As I briefly introduced earlier, analgesics that function through the disruption of nociceptive signals can be explained by the gate control theory of pain. Now let's take a look at a very simplified figure to visualize what's going on with this theory. So on top you have your type 3 and 4 nociceptors. At the periphery, so for example near the rupture site on a muscle, there is the noxious stimuli. We have chemical noxious stimuli with a perpetual stimulation of type 4s causing dull, throbbing pain in the form of muscle soreness, and of course, sharp, immediate pain upon mechanical perturbation because both type 3s and 4s are now hypersensitive to any mechanical stimuli. As with all sensory nerve fibers, signals through the nociceptors travel towards the spinal cord to a particular area called the spinal lamina. Here in the spinal lamina, we have a couple types of spinal neurons. First, as denoted by the red figure and the letter I, we have an inhibitory interneuron. And represented by the green figure and the letter P, we have the projection neuron. The minus and plus signs represent inhibition and activation of each of these spinal neurons respectively. So let's take a look at what's happening first with the nociceptor in response to a noxious stimuli like during a muscle strain. As described in detail earlier, the presence of noxious stimuli stimulates particular receptors at the peripheral ends of the nociceptors at the axon terminal. The receptors respond when it reaches a stimulation threshold, at which point the receptor response will cause depolarization of the nociceptor and generation of an action potential. The action potential represents the nociceptive signal and is denoted by the lightning bolt in this figure. The signal, as we know, is afferent, so it propagates towards the CNS, specifically to the spinal lamina. First, this signal will cause an inhibition of the inhibitory interneuron. The inhibitory interneuron is a short neuron that functions only to inhibit the projection neuron, as denoted by this minus sign here. So as a result of inhibiting the inhibitory interneuron, the projection neuron is no longer inhibited by it. So in a simplified summary, this nociceptive signal stops the inhibitory interneuron from blocking the projection neuron. In addition, the nociceptive signal also activates the projection neuron. So altogether, since there is no more inhibition of the projection neuron, and at the same time there is activation of the projection neuron from the nociceptive signal, the net result is the activation of the projection neuron. The projection neuron then proceeds to transmit or project that nociceptive signal to the brain, where the signal can be encoded to generate the perception of pain. So with that being said, basic logic would suggest that if somehow this signal was prevented from reaching the brain, we would experience pain relief or analgesia. The gate control theory suggests that this is possible. So before we talk about the modalities that work through this mechanism, let's discuss the fundamentals first. Down here, we have a figure of another sensory neuron classified as a type 2 nerve fiber, or group A beta. These sensory nerve fibers are not fundamentally nociceptors, but another class of sensory neurons called mechanoreceptors. Now, as I mentioned before, type 2s can eventually become nociceptive to some minor extent when there is high levels of chemical noxious stimuli, but they are not fundamentally mechanoreceptors. So what are mechanoreceptors and what do they detect? Mechanoreceptors are responsible for the sensation of touch or mechanical changes to peripheral tissues like muscle. So for a simple example, when you touch something with your pointer finger, that sensation is elicited by the activation of these type 2 mechanoreceptors that innervate the subcutaneous area of the pointer finger, right underneath the skin. Also, for another example, when we shorten or lengthen our muscles, we sense that. That sensation is due to type 2 mechanoreceptors that innervate certain parts of the muscle. So the type of stimuli that these mechanoreceptors respond to are mechanical stimuli. So let's talk a little bit about the characteristics of these type 2 mechanoreceptors. When you touch something, do you feel it instantaneously, or is there a delay before you realize the touch sensation? You would feel it instantaneously, right? At least if you have a healthy functioning nervous system. So what does this tell you about the speed of the signal conduction from the periphery, like say from your hand, all the way to the brain? It's relatively fast. In fact, the type 2 mechanoreceptors are the second fastest of all 4 sensory nerve fibers. Their conduction velocity is about 33 to 75 meters per second. To reiterate, the type 3 nociceptor has a conduction velocity of 5 to 40 meters per second, and the type 4's only 0.5 to 2 meters per second. This means that the mechanical signal through the type 2 mechanoreceptors propagate to the CNS many times faster than the nociceptive signals through the types 3 and 4 nociceptors. So hold on to that thought and we will circle back around to it. First, let's follow the signal propagation through the type 2 mechanoreceptors as reflected by these lightning bolts. As it reaches the spinal lamina, as you can see by the plus sign here, the mechanical signal is going to activate the inhibitory interneuron. Remember, the inhibitory interneuron, when activated, in turn inhibits or blocks the projection neuron. So now you can see that there is competition with the nociceptive signals coming from the nociceptors. The nociceptors will inhibit the inhibitory interneuron and activates the projection neuron. But the type 2 mechanoreceptors activate the inhibitory interneuron, which would block the projection neuron. So overall effects on the projection neuron is as such. Nociceptors activate it and type 2 mechanoreceptors inhibit it. So who wins? The nociceptive signal or the mechanical signal? Well, let's go back to the conduction velocity. Which one again was faster? The mechanical signal via the type 2s are faster. They will reach the CNS, the spinal lamina, faster than the nociceptive signal from the type 3s and 4s. This means that the signals that activate the inhibitory interneuron occur at a faster rate than the signals that inhibit the inhibitory interneuron. And thus the net effect would be an inhibition or blockage of the projection neuron. As a result, the nociceptive signals are less projected towards the brain, and thus you have decreased pain. Now, is it a total blockage of nociceptive signal towards the brain? No, not at all, but rather less nociceptive signals reaching the brain. So as you can see, the type 2 mechanoreceptors do not work through the same projection neurons as the nociceptors for the mechanical signal to reach the brain. So the mechanical signal effectively reaches the brain, and you have the sensation of touch or mechanical changes to the tissue. So in a sense, by activating those mechanoreceptors, the mechanical signals are not only blocking the gate by which the nociceptive signals reach the brain, but it also does it by replacing the sensation of pain with the sensation of touch or some mechanical change to the peripheral tissue. All right, so now that we understand the fundamental basis of the gate control theory and nociceptive signal inhibition through the mechanoreceptors, what are the practical analgesic approaches that work through this mechanism? Well, the analgesic approach would need to involve something that will provide mechanical stimuli to these type 2 mechanoreceptors. Arguably, the most common and most effective acute pain management strategy following muscle injury is TENS, Transcutaneous Electrical Nerve Stimulation. TENS involves the use of a device that emits electrical impulses as well as surface electrodes that are placed on the skin, usually around the injury site. Transcutaneous means crossing the skin. So these electrical signals are emitted at a frequency and intensity that can cross the skin and depolarize/activate the type 2 mechanoreceptors in the subcutaneous area right underneath the skin. Now, during TENS, the electrical signal, both in its frequency and intensity, is not enough to stimulate motor neurons to contract muscle. So during TENS, you should not experience muscle contraction. That occurs with EMS, which is electrical muscle stimulation, also simply referred to as muscle E-stim. TENS is a totally different protocol and with a different intent. Muscle E-stim is not for pain relief. It is for healing, particularly regeneration, but we will discuss that later. TENS is a low frequency and low intensity electrical signal that is just enough to activate the subcutaneous type 2 mechanoreceptors. And the sensation you get during TENS is similar to that of touch. It is a tingling type sensation as if a bunch of needles are lightly poking you. In other words, TENS stimulates these mechanoreceptors without the need of a mechanical stimuli. In the acute treatment phase, this would be highly beneficial. Why? Well, because during this immediate post-injury time frame, the nociceptors are very sensitive to mechanical stimuli. Remember, as I indicated earlier, that chemical noxious stimuli makes the nociceptors much more sensitive to mechanical stimuli. Thus, applying actual mechanical stimuli during this phase, for the sake of pain relief, would actually be counterproductive, since it will likely cause more immediate sharp pain. So how can we stimulate the type 2 mechanoreceptors to disrupt the nociceptive signals without actual mechanical stimulation? Again, this is where TENS comes in. Through TENS, we can stimulate the type 2 subcutaneous mechanoreceptors without the need of an actual mechanical stimuli. Now, I did, however, list some manual therapies here that may work through the gate control mechanism of pain relief by providing a mechanical stimulus. However, in the acute treatment phase, as I said, this would not be the best approach again because nociceptors at this point are hypersensitive to mechanical stimuli. But these manual therapies can be beneficial for pain relief when much of the hyperalgesia or tenderness has subsided. When the hyperalgesia has dissipated, that is an indication that inflammation has been reduced and the nociceptors may not be as sensitive to mechanical stimuli. In practical terms, you may describe the situation as muscles being sore with some dull pain, but not tender and not hypersensitive to mechanical stress, like with stretch, contact, or contraction. At this point, these manual therapies may be used. But initially in the acute treatment phase, TENS would be the best approach to utilize this gate control mechanism for pain relief. Now, there are tons of misperceptions regarding these manual therapies, and that many claim that they provide benefits following a muscle injury by facilitating regeneration and breaking down scar tissue. I will be upfront and say that these claims are not at all substantiated, even to a minimal degree, by scientific evidence. You may hear more often than not that these manual therapies, as listed here, for example, quote unquote, break up scar tissue. This just does not occur, and you would understand that if you understood the physiological characteristics of scar tissue, which I explained briefly previously. You can't break up or scrape away intramuscular scar tissue. Theoretically, if you added enough compression or shear force to break scar tissue, which by the way you wouldn't be even able to locate since it's under your skin, you would simply just cause damage to the muscle. Permanent scar tissue is integrated into the muscle tissue. Remember, over time, the muscle fibers adhere to the scar tissue with costomeres. So if you were able to apply enough compressive or shear force to break up scar tissue, you would actually just damage muscle tissue, which would not at all be conducive to muscle integrity. In addition, you would also likely damage skin and blood vessels along the way, since a lot of force would need to be applied to be able to quote-unquote break up scar tissue. Again, scar tissue is connective tissue that is literally adhered to the muscle. It's not something you can just peel away or break off. So I guarantee you that you will hear many individuals in the field talk about scar tissue removal therapies, but I can also guarantee you that they would not be able to properly explain in a scientifically sound manner the mechanism through which that occurs. Why? Simply because there is no supportive mechanism by which this can occur. So these manual therapies and their potential effects on pain relief, again, when hyperalgesia has subsided, works through the gate control mechanism and not through some physical changes to the muscle itself. It is entirely a neural mechanism. No scar tissue breakdown, no quote unquote loosening of muscle, no physical changes to the muscle itself. I also do want to add, because it is an area of common misperception for many, that manual therapies like massage, scraping, the use of percussive therapy using a Theragun, for example, have been touted by many to help reduce tightness and improve range of motion, because there's less sensation of tightness restricting the movement. Well, many people also believe that this reduced tightness upon applying these manual therapies is due to the literal loosening of muscle tissue, as if the muscle is in some physical tense state, like a thick rubber band. The acute effects of these manual therapies on tightness is also purely through neural mechanisms. First, what is tightness? To many, it's a physical property in an object. But in physiology, tightness is simply a sensation. It's a mechanically derived sensation. Tightness is the baby cousin of pain. It is derived from low-level nociceptive signals. Let me expound. Remember, nociceptors can be stimulated by mechanical stimuli, such as when you stretch a muscle. As you stretch the muscle further, the mechanical stimuli intensifies. As it intensifies, the sensation slowly turns into pain. First, it's discomfort, then as you stretch more, it eventually becomes pain. This is how range of motion for any individual is regulated. It is regulated by the nociception/pain and the stimulation threshold of the mechanical nociceptors. Now, there are situations in which a muscle feels even quote-unquote tighter, and range of motion is limited by this perception of tightness. The common reason why you feel tight at times, again, tightness just simply being low levels of pain, is because the mechanical stimulation threshold on the nociceptors was lowered, meaning it has become more sensitive to lower levels of mechanical stress, like when you stretch. This occurs oftentimes when the muscle has undergone damage or injury. Why do you think the mechanical stimulation threshold of nociceptors is lower during these situations, other than the fact that there may be inflammation and increased chemical noxious stimuli? Fundamentally speaking, it is to protect the muscle from tension, like when you stretch. The sensation of tightness is just low levels of nociception intended to protect the muscle from overtension. So the sensation or feeling that your injured muscle is quote unquote tighter is all mediated through neural mechanisms, through a lowered mechanical stimulation threshold on nociceptors. So this is why manual therapies help acutely or temporarily reduce the sensation of tightness. Manual therapies through the gate control mechanism simply disrupts the nociceptive/tightness signals responsible for the perception of tightness. It has nothing to do with the changes to physical properties of the muscle. Physical changes to muscle occurs as a result of long-term adaptation, not after a single session of manual therapy. So next time you get a sports massage or a deep tissue massage and you feel that the tightness sensation has decreased, understand that it is all through neural mechanisms, through the type 2 mechanoreceptor activation and the gate control mechanism. It is through the inhibition of the tightness/nociceptive signals. Okay, now let's discuss another mechanism of nociceptive inhibition that is sort of like the gate control theory and concept, but a very different mechanism of action overall. Now, this approach is arguably the most common and most practical approach to analgesia, especially during the acute treatment phase, or just generally the early phases post-injury when soreness and hyperalgesia is the highest. This mechanism involves the manipulation of type 3 and 4 nociceptors through the application of thermal stimuli. Type 3 and 4 nociceptors, as introduced earlier, are not only responsive to mechanical and chemical stimuli, but also thermal stimuli. They express thermoreceptors on its axon terminal. If you go back to the detailed slide of all the receptors, you will be able to see the thermoreceptors on that axon terminal of the nociceptor. These thermoreceptors are namely TRPM8 for cold stimuli and TRPM3 for heat stimuli. In extreme amounts of either stimuli, we obviously know that it can cause nociception and pain, but in tolerable amounts, these receptors cause thermal sensation. Now, during hyperalgesic situations like following a muscle strain, these thermoreceptors can essentially compete with the chemoreceptors on these sensory nerve fibers. Thus, thermostimuli competes with the chemical noxious stimuli associated with inflammation and muscle fiber damage. Therefore, when a thermostimulus is present, more nociceptors around the injured site would become activated in response to thermal stimuli as opposed to chemical noxious stimuli. Therefore, thermal sensation will supersede pain sensation when thermal stimuli is applied to the injured area. In addition, when the nociceptors are thermally stimulated, there is a temporary period of desensitization of the nociceptor to various stimuli, including the chemical noxious stimuli. In other words, the thermostimulation increases the stimulation threshold for the nociceptors. And we can easily experiment with this by just simply taking hands out of warm water and immediately putting it into ice cold water. Initially, it hurts, but after some time passes, the pain goes away. This is because through the constant thermal stimulation by the ice water, the nociceptor stimulation threshold increases and thus become less sensitive to noxious stimuli, to all noxious stimuli, including chemical noxious stimuli. So how can we apply thermal stimuli? Well, the clear way is through icing or some form of cryotherapy, whether it is locally applied or applied to the whole body, like with ice baths. Heat can also provide thermal stimulation of nociceptors as well, but ice or cryo treatments are more preferred, especially during the acute treatment phase. And this is due to the other effects it has that would benefit an athlete following a strain, such as control of edema through vasoconstriction, as well as its minor anti-inflammatory effects. Heat does not provide those particular benefits. So you're essentially killing 3 birds with 1 stone by using cryo treatments in the acute treatment phase as opposed to heat. This is why the police principle involves icing and not heat. Heat is more preferred as a thermal stimulator through later stages of post-injury care when edema and inflammation is not much of a factor. And at this point, heat can be used to reduce dull pain or soreness and also reduce the feeling of tightness, which again I said was the baby cousin of nociception. Now, other ways we can trigger thermal receptors, particularly the TRPM8 cold receptor, is through chemical induction, meaning there are certain chemicals that can trigger these TRPM8 cold receptors without any cold application. A chemical that is a TRPM8 agonist or activator is menthol, which I'm sure you are familiar with to some extent. Ointments such as Biofreeze, Bengay, and Icy Hot all contain menthol. And we all know when you apply these ointments, you feel a cooling sensation. But the ointment is not cold in temperature, right? So why do you think you feel a cooling sensation? It is because menthol triggers the TRPM8 receptors and thus triggers thermal cold sensation. And just like icing, perhaps not as potent however, it can reduce the chemical activation of nociception by competing with chemical receptors on those nerve fibers, as well as desensitize the nerve fibers to noxious stimuli. So in summary, nociceptive disruption or inhibition as an analgesic approach works through 2 main mechanisms. One, through the gate control mechanism via stimulation of type 2 mechanoreceptors, especially through the use of TENS, at least in the early post-injury phases. Or 2, through light to moderate thermal stimulation of nociceptors to compete with chemical noxious stimuli and chemical receptors, and to desensitize nociceptors to all noxious stimuli. And again, cold thermal stimulation is preferred versus heat thermal stimulation for analgesia, particularly in the early post-injury phase, because cold treatments can kill 3 birds with 1 stone. It can also control edema as well as exert minor anti-inflammatory effects to help control situations of excessive inflammation. Alright, so other than nociceptive signal inhibition, what was the other target for pain management following a muscle strain? It was the acute inflammation and the associated chemical noxious stimuli. So there is the anti-inflammatory analgesic approach, which is largely through pharmacological interventions. So let's discuss the major pathway through which anti-inflammatory drugs exerts its analgesic effects. First, the pathway. The pathway you see here, which we will break down in a second, is referred commonly as the Cyclo-Oxygenase Pathway, which involves the enzyme Cyclo-Oxygenase 1 and 2. Following damage to muscle tissue, like following a strain, there is increased activity of the enzyme phospholipase A2. This is stimulated primarily by pro-inflammatory cytokines released by inflammatory/immune cells, also including is calcium ions as well as growth factors. These factors increase the activity of phospholipase A2. Phospholipase A2 hydrolyzes or breaks apart phospholipids, which are lipid molecules combined with the phosphate. Phospholipids are abundant within cells like muscle cells, as they make up the cell's membrane. Upon hydrolyzation of phospholipids, arachidonic acid is released from the phospholipid structure. Downstream of that, arachidonic acid undergoes modification by cyclooxygenase 1, followed by cyclooxygenase 2. And as a result, arachidonic acid is modified into active compounds called eicosanoids. eicosanoids. And eicosanoids are important signaling molecules for diverse physiological systems and processes, including inflammation. The specific eicosanoid here is prostaglandin, particularly prostaglandin H2, or PGH2 for short. PGH2 is an important signaling molecule that mediates inflammation during tissue injury, like following a muscle strain, and various enzymes in the body can act upon PGH2 to produce other eicosanoids. In relation to nociception, the two prostaglandins derived from PGH2 are PGF2 alpha and PGE2. These two prostaglandins are inflammatory chemicals that are known noxious stimuli and is one of the more potent noxious factors that mediate pain and hyperalgesia during tissue injury situations. So here we have the pathway, and pharmacology over many years discovered the means to chemically manipulate this pathway for the sake of pain relief. The two classes of painkillers that act on the cyclooxygenase pathway include non-steroidal anti-inflammatory drugs, or NSAIDs, and corticosteroids, with the latter being of greater potency and thus requires a prescription. Popular NSAIDs include ibuprofen, aspirin, naproxen, and celecoxib, commonly known as Celebrex. Now, NSAIDs all generally act on the same part of this cyclooxygenase pathway, but with slight differences, as I will discuss later on. But generally speaking, NSAIDs are cyclooxygenase inhibitors, and thus the biological targets for NSAIDs are cyclooxygenase 1 and or cyclooxygenase 2. Some NSAIDs are non-selective cyclooxygenase inhibitors, meaning they inhibit both cyclooxygenases, while some are selective cyclooxygenase inhibitors, meaning they can inhibit one of the cyclooxygenase more so than the other. We will discuss which those are and the clinical implications in a few moments. So as you can see in this figure, NSAIDs inhibit the cyclooxygenase enzymes. So knowing what you know thus far about cyclooxygenase, we know that if cyclooxygenase is inhibited, there's going to be reduced conversion of arachidonic acid to prostaglandin H2. In so doing, there is less PGF2 alpha and PGE2 formation, and thus less of these potent noxious stimuli. Now, synthetic corticosteroids exert similar effects but act on the pathway upstream of cyclooxygenase. As you can see here, synthetic corticosteroids, which are often referred to as simply steroid shots, primarily inhibit the enzyme phospholipase A2, which, if you remember, breaks down phospholipids to form arachidonic acid. Corticosteroids, usually in the form of cortisone, is administered via intramuscular injection, and thus the analgesic effects are quite potent and almost immediate. So as I've alluded to many times, the effects of anti-inflammatory drugs is a paradoxical one, because although it helps with pain relief, it inhibits a pathway that is also critical in the initiation of regenerative healing. Particularly, prostaglandin E2 is a key mediator of muscle regeneration through its action on muscle stem cells like satellite cells, which, as I've discussed earlier, are the building blocks of muscle fiber regeneration. PGE2 is synthesized through this cyclo-oxygenase pathway, particularly through the reaction catalyzed by the enzyme prostaglandin E synthase, which converts PGH2 to PGE2. In the video caption, I will provide a link to a 2017 study which I believe was one of the more well-designed animal studies to investigate the role of PGE2 in muscle regeneration. Studies show that by blocking PGE2 by ablating its receptor on muscle stem cells or by inhibiting the production of PGE2, there is a significant reduction in muscle stem cell activity and muscle fiber regeneration following injury or damage. Also in this particular 2017 study, researchers found that PGE2 injections resulted in enhanced and accelerated regeneration and repair of damaged muscle. This shows the critical role of PGE2 in muscle regeneration following injury. Overall, research in this area concludes that inhibition of PGE2 production through high-dose/excessive NSAID use following muscle injury may hinder regeneration and compromise the quality of healing. And remember, quality of healing is defined as a greater regeneration to scar tissue formation ratio. We want less fibrosis and more regenerated muscle fibers to support greater functional and structural healing and optimal late functional recovery. This is especially critical for athletes who will be returning to the high muscular demands of their sport. Now, with this scientific evidence, practical application in sports medicine, particularly in muscle injury care situations, must be modified accordingly. Unfortunately, there is still heavy use of NSAIDs, again because people generally like pain relief. But always remember that pain is a necessary evil. It is critical feedback to properly guide optimal loading especially, which I mentioned is important for early functional recovery and thus the road to late functional recovery. So pain should not be totally eradicated because you need that sensory feedback. Without it, you run the risk of overloading the muscle prematurely and causing further damage to the injured muscle, which of course will be counterproductive as it would delay healing and reduce the quality of healing. So the use of NSAIDs more recently has been drastically reduced by evidence-based practitioners. Because of this evidence, practitioners are turning to more prudent approaches to pain management that do not hinder the regenerative process. Thus, anti-inflammatory drugs are less used as the primary means for analgesic intervention, especially immediately following muscle injury. Rather, they are only employed to control excessive inflammation with severe injury cases early in the post-acute treatment phase, but the dosing is only temporary and it's also small doses. As I mentioned earlier, icing, especially during the acute treatment phase, has shown over many years of research to be one of the most practical approaches as it has a relatively weak yet practically meaningful anti-inflammatory effect to simply control excess inflammation and thus degradation of healthy muscle fibers, while at the same time reducing edema. Icing also has analgesic properties, not so much through anti-inflammation, but rather through nociceptive signal disruption as described earlier with thermal stimulation. Now, just to present some relevant evidence, here we have a classic rodent model study by Shen et al. Now, this is described as a mechanistic study to better understand the mechanisms that underpin the effects of cyclo-oxygenase inhibition on muscle regeneration. Oftentimes, a rodent model is used for the primary sake of control, especially factors that are difficult to control in human model research. Now, this study used a common rodent model called a knockout model. A knockout model involves the genetic ablation of a particular gene that codes for a particular protein. In this study, researchers used a cyclooxygenase 2 knockout rodent model, and that rodents were bred deficient of the COX2 enzyme. This is through the quote-unquote knockout of the gene that encodes for the cyclooxygenase 2 enzyme. The control group in this study would obviously be rodents that presented with the cyclooxygenase 2 enzyme as normal. This type of control group in rodent model studies is referred to as wild type, indicating that this group of rodents were quote-unquote normal with no genetic or biochemical modifications. So as you might have guessed from the description of the two groups of mice, researchers aim to investigate the effects of cyclooxygenase 2 deficiency on skeletal muscle regeneration after injury. So in both groups of rodents, muscle injury was administered via laceration, of course under anesthesia. A subgroup of rodents in each group were sacrificed at 5 days post-injury and the other subgroup at 14 days post-injury to harvest tissue, so they can analyze the injured muscle. One of the techniques they use to analyze the structural changes in the muscle is muscle histology. Histology is a technique that involves the imaging of tissue or cells through the use of a microscope. And here we have samples of their histological images of muscle samples in each group for both time points that are representative of the overall findings. So let's look at 5 days post-injury images between the wild type and the cyclooxygenase 2 knockout mice. The red portions of the images represent muscle fiber cross-sections, and the lighter portions represent fibrotic tissue, namely connective scar tissue. As you can clearly observe just subjectively, you can see in the cyclooxygenase 2 knockout group, there was a significantly greater presence of fibrotic tissue in the muscle versus the wild-type control group. Just by the image comparison, you may conclude that without cyclooxygenase 2, there is impaired regeneration to scar tissue formation ratio. This conclusion is supported by their quantitative data analysis as shown here in this graph. On the y-axis, you have number of regenerating fibers at day 5 and at day 14 post-injury. As you can see, the wild-type control group has significantly greater number of regenerating fibers versus the cyclooxygenase 2 knockout group at both day 5 and day 14 post-injury. So let's look at day 14 post-injury histological images. At day 14, based on subjective assessment of these histological images, the cyclooxygenase 2 knockout group had less quality healing, as you can see a greater presence of fibrotic tissue versus muscle tissue. And again, the data analysis supports this assessment at day 14. The cyclooxygenase 2 knockout group had a significantly lower number of regenerating fibers versus the wild-type control group. So although animal studies are not intended to be practically applied to humans immediately, these findings provide a picture of the potential mechanisms by which cyclooxygenase 2 inhibition through high-dose NSAID use negatively affects healing quality following muscle injury. So if you wanted to extrapolate these histological analyses to humans, the figures on the right may represent high-dose NSAID use, and the figure on the left may represent no NSAID use or small-dose NSAID use following muscle injury. Now, in a separate study, investigators examined the effects of a cyclooxygenase 2 inhibitor called NS398, which can be generally described as a similar compound as NSAIDs. Researchers compared the quality of healing post-muscle injury among several groups. You had the control group that received no cyclooxygenase inhibitor, a group that received low dose and short duration of the cyclooxygenase inhibitor at 5 milligrams for 3 days, a group that received low dose and longer duration of the cyclooxygenase inhibitor at 5 milligrams for 5 days, and lastly, a group that received high dose for short duration of the cyclooxygenase inhibitor at 10 milligrams for 3 days. Muscle samples were taken from each group at 14 days and 28 days post-injury and stained for fibrotic tissue using special chemicals that stain fibrotic tissue blue. The results showed that at 14 days post-injury, the control group contained less fibrotic scar tissue than all groups who received the cyclooxygenase inhibitor. Furthermore, the low-dose short-duration group contained less fibrotic tissue than the high-dose short-duration and low-dose long-duration groups. This suggests that both dosage and duration of dosing of cyclooxygenase 2 inhibitors may influence quality of healing, and that lower dosage and durations yield more favorable results. At the 28-day post-injury time point, it appears that there was no statistically significant differences in scar tissue levels in either group. But as you can see by the graph here, the average amount of scar tissue was less in the control group and increased with greater dosage or duration of the cyclooxygenase inhibitor. So as you can see by these mechanistic studies, cyclooxygenase inhibition, say through high dose or long duration NSAID use, may not be favorable for quality healing, as it appears to worsen the regeneration to scar tissue formation ratio. And as we discussed a couple slides back, this may be due to the reduced level of PGE2, which, as I said, was an important mediator of muscle regeneration. So yes, you will have reduced pain, but it may come at the expense of quality healing. Now, of course, there's always the question of side effects when it comes to any drug intervention, and NSAIDs are not at all exempt from this question. One of the reasons why all drugs have side effects is because their biological targets are rarely specific to any one particular physiological system, organ, or cell. For example, the cyclooxygenases are enzymes present in other organs other than skeletal muscle. For example, cyclooxygenase 1 in the gastrointestinal mucosa, or simply the gut, increases PGE2, which in this organ system increases gastric protection through increased mucus secretion, bicarbonate, and mucosal blood flow. So one of the most common side effects of high-dose NSAID use is gastrointestinal distress. And this is because when cyclooxygenase 1 is inhibited by NSAID use, there is less PGE2 and thus reduced gastric protection. This is why heavy NSAID use could lead to gastrointestinal complications, which include peptic ulcers and GI bleeding. This is especially the case with heavy aspirin use, which is a cyclooxygenase 1 and 2 inhibitor, but slightly more selective of cyclooxygenase 1. Other side effects involve the kidneys and renal function. Inhibition of both cyclooxygenases 1 and 2 in the kidneys will reduce the prostaglandins PGE2 and PGI2, which are important factors that mediate glomerular filtration rate, or GFR, and increase sodium and water excretion. So through the inhibition of the cyclooxygenases in the kidney or the renal system, there will be side effects such as those listed here. In the cardiovascular system, cyclooxygenase 1 increases PGI2, while cyclooxygenase 2 increases thromboxane. Cyclooxygenase 2 and thus PGI2 promotes vasodilation and inhibition of platelet aggregation, and thus inhibition of thrombus formation or blood clot formation. Cyclooxygenase 1 and thus thromboxane does the complete opposite. In normal situations, cyclooxygenase 1 and 2 are regulated and balanced within the cardiovascular system. And of course, if cyclooxygenase in the cardiovascular system is manipulated, such as with heavy NSAID use, this balance can be disrupted and lead to increased risk for cardiovascular complications. For example, when there's greater cyclooxygenase 2 inhibition versus cyclooxygenase 1 inhibition, this would increase the risk for stroke and heart attack because you will have less vasodilation and more platelet aggregation, which means more thrombus formation, since PGI2 would be inhibited to a greater degree. Now, if you have more cyclooxygenase 1 inhibition versus cyclooxygenase 2 inhibition, then you would gain some positive cardiovascular protective effects, especially in high cardiovascular disease risk situations, like those who are severely hypertensive. This is because by inhibition of cyclooxygenase 1 and thus thromboxane, you would have less platelet aggregation, which would help reduce thrombus or blood clot formation, and also less vasoconstriction. This is why low-dose aspirin is commonly prescribed to those with high cardiovascular risk, such as hypertensive individuals. Remember, aspirin is weakly more selective of cyclooxygenase 1 than 2. So you would get more cyclooxygenase 1 inhibition than cyclooxygenase 2 inhibition, which again would produce cardioprotective effects compared to greater cyclooxygenase 2 inhibition. Now, I want you all to do some critical thinking here and address the questions presented here in relation to this anti-inflammatory paradox. With the information given thus far, you should be able to address these questions adequately. In addition, I would like you to take a look at these two articles here regarding the effects of cryotherapy on regeneration. And as a little bit of a hint for you to answer these questions regarding cryotherapy, remember cryotherapy has a weak anti-inflammatory effect and may only help during situations with excessive inflammation to help control excessive degradation and necrosis. But does this weak anti-inflammatory effect influence regeneration? And does it even influence pain through anti-inflammation? We discussed earlier how cryotherapy can be a potent analgesic, but not so much through the anti-inflammatory pathway, but rather through nociceptive signal disruption. So think about those concepts and try to answer these questions here. These are two articles that will present evidence to assist with your critical thinking. Now, don't spend too much time dissecting this article. Just grasp the overall purpose of the study design, and their conclusions based on the evidence gathered. Okay, now that we've covered pain management and the analgesic mechanisms, which again include nociceptive signal disruption and anti-inflammation, let's circle back now to the acute treatment principles, particularly the police principle. Let's focus on the recent modification to rest in the price principle. Recently, with evidence as referenced below, rest has been modified to optimal loading. As described here simply, optimal loading is controlled mechanical stress through manual therapies initially, while rested to promote regenerative processes that respond to mechanical tension, such as loaded or resisted contractions. This loading eventually progresses away from manually resisted therapy to exercise therapy. And as I said earlier, optimal loading, early functional recovery, and early mobilization all refer to the same concept. So why is optimal loading in the acute treatment phase important, and how does it influence regeneration and thus quality of healing? Remember, loading skeletal muscle, like with resistance training, elicits adaptations directly in response to mechanical stress/tension. These adaptations manifest in improved functional and structural strength. Why? Because mechanical stress promotes anabolic processes like muscle protein synthesis, as well as regenerative processes like those involving muscle stem cells. Thus, applying this same principle of resistance training adaptation to muscle injury situations can promote quality healing, which involve both structural and functional healing to facilitate the restoration of structural and functional strength. Of course, during the acute treatment phase, since the muscle is vulnerable to re-rupture, loading should be optimized for that situation, hence optimal loading. Meaning loading initially during the acute treatment phase should be very light and thus afforded through manual resisted therapy. This is aided largely by a therapist or athletic trainer in the sports med settings. Also, the use of TheraBands and simply gravity also provides the ability to apply optimal loading during the acute treatment phase without exposing the muscle to too much tension and mechanical stress. So with that said, let's put it all together and summarize the fundamentals of acute treatment strategies based on the police principle. So first, as emphasized earlier, a huge goal within the acute treatment phase is to minimize the wound gap through the careful control of excessive inflammation and swelling. In addition to this, acute treatment should also be fundamentally focused on the improvement of early mobilization/early functional recovery. This is primarily through the careful and controlled management of pain, since pain is the only limiter of function that can be manipulated early on. The other limiters, ultrastructural damage and motor neuron reinnervation, are factors that cannot be directly and immediately manipulated. These factors are resolved during the subsequent repair and remodeling phases naturally. In addition to pain management, early mobilization and early functional recovery can be aided indirectly by minimizing the wound gap, which can improve structural integrity early. Now, the purpose of improving early mobilization is to facilitate the application of optimal loading, which I said promotes regeneration and thus quality of healing through careful and progressive mechanical stress to the muscle. In so doing, late functional recovery may be further optimized. This is why early mobilization/early functional recovery is a critical step. So once again, what can be done to facilitate early mobilization? Pain management is the primary approach, and we discussed the different mechanisms earlier through which this can occur. So what about the evidence? There's a mixture of mechanistic and human clinical trials to support the importance of early mobilization on late functional recovery. This figure here is a culminating representation of the rehab trajectory following muscle injury between those that incorporated early mobilization and those who remained immobilized during the early phases post-injury. Here we have a 42-day post-injury time frame on the x-axis, and strength as a measure of muscle function on the y-axis. During the first 2 days post-injury, the injured muscle was completely immobilized in both groups, as you can see here denoted by the abbreviation IMMO. And this was afforded through casting of the limb on which the muscle was injured on. Now, starting at the day 2 post-injury time point, these subjects represented by the blue line incorporated early mobilization and thus optimal loading through manual therapies, and the MO stands for mobilization. And this group represented by the yellow line had their injured muscle continually immobilized. This continued all the way up to 21 days post-injury. So in between 2 to 21 days post-injury, the early mobilization group demonstrated greater improvements in muscle function early on, i.e. early functional recovery, compared to the group who remained immobilized. You can see by the shaded black area here the difference in early functional recovery between the two groups. At day 21 post-injury, the early mobilization group continued to mobilize and at this point has progressed in loading and likely incorporating strength exercise. The other group at day 21 post-injury began mobilizing the injured muscle. Now, as you can see, by day 21, the early mobilization group has recuperated their full functional capacity, as you do not see any further changes from day 21 onward. This means that they have achieved full late functional recovery by day 21 post-injury and is close to return to sports status, as long as sports-specific performance was recovered fully as well. Now, as you can see in the group that did not incorporate early mobilization, there is delayed functional recovery, and late functional recovery was not optimized by day 21. These subjects were not fully recovered and thus were not in a return to sports status by day 21. Even at day 42, their late functional recovery was not at the level of the group who incorporated early mobilization. And as indicated by the shaded red area, you can see the difference in late functional recovery between the two groups. So if I ask what is the underlying mechanism of this effect by early mobilization, it would be the application of progressive optimal loading early on, which facilitates regeneration and anabolic processes in muscle through mechanical stress. Thus, the regeneration to scar tissue formation ratio improves, and thus structural plus functional healing improves. Overall, you gain better quality healing and thus optimum late functional recovery. So by now you can see why progressively loading the muscle post-injury is critical to late functional recovery and more specifically healing. And of course, loading should eventually progress enough so that it is afforded through exercise therapies and not just manually resisted therapies. This is why exercise is the cornerstone of physical therapy practices. In essence, exercise therapy through the progressive loading and thus progressive mechanical stress is regenerative medicine. And there is evidence to suggest exercise is the most critical modality to facilitate regeneration of injured muscle, even compared to non-exercise regenerative medicines such as platelet-rich plasma therapy or PRP. PRP is a modality that involves the extraction of blood plasma from the patient. Plasma is rich with platelets. As I mentioned earlier, platelets mainly function to form blood clots and to stop bleeding from ruptured blood vessels, but platelets are also very rich in growth factors, which we know are critical signaling molecules for growth and healing processes in a variety of tissues. When the plasma is collected from the patient, the platelets are extracted and placed and concentrated into solution. This solution, now rich with the patient's own platelets, are then re-injected back into the patient, but at the location of the muscle injury. Therefore, the platelet concentration at the injury site is now very high. The idea here is for the platelets to release and concentrate the area of injury with growth factors to help stimulate healing processes. Now, notice I didn't specify regenerative healing, but healing in general. PRP promotes general healing, but not specifically regenerative, although improved regeneration is a more profound effect of PRP treatment. But you also have increased fibrogenic healing as well through scar tissue formation, because some of the growth factors released by platelets include those that facilitate fibrogenesis, including transforming growth factor beta, TGF beta, which we introduced in our first lecture. However, like I said, PRP does favor more regeneration than fibrogenic healing. So it is described generally as regenerative medicine. So how does exercise therapy compare to PRP in a muscle injury situation? In this mechanistic rodent model study, researchers compared the healing quality following muscle injury among several treatment groups. One group was untreated post-injury, and another received saline injections. These two are the control groups. Another group received PRP injections only, another group received PRP injections and exercise intervention, and lastly, a group that only received exercise intervention. And again, muscle samples were extracted to compare histologically the quality of healing. In the top row of figures, the red areas represent muscle cells, while the lighter shaded area reflect fibrotic tissue, like scar tissue. On the bottom row, these figures reflect images obtained following a chemical stain of type 1 collagen proteins, which are largely found in connective tissue, especially scar tissue. As a result, scar tissue will be stained green, and this technique to image the stain sample is a specific technique called fluorescence. Now, overall, PRP, exercise, and PRP plus exercise treatments improved overall healing quality compared to untreated and saline control groups. However, exercise alone improved quality of healing to a significantly greater extent than PRP alone. However, there was no clear synergistic effects of a combined PRP plus exercise intervention on healing quality. If you look at the quantitative data here, the y-axis represents myofiber cross-sectional area, which is a measure of muscle fiber size. As you can see, the exercise-only intervention yielded superior outcomes versus all other groups in terms of myofiber CSA changes. As far as scar tissue formation is concerned, here on the y-axis we have area density of collagen 1, which again is a collagen fiber protein that is largely found in fibrotic scar tissue. As you can see, the two groups that had an exercise intervention, the PRP plus exercise group and exercise only group, yielded the lowest values, indicating that exercise therapies reduce scar tissue the greatest compared to PRP alone, as well as the control groups. So what about regeneration? Is exercise therapy superior in promoting regeneration of muscle tissue following a muscle injury? The researchers conducted a separate analysis utilizing a lab technique that stains a protein called DMHC, developmental myosin heavy chain. This protein is only found in developmental muscle fibers. These are not fully matured muscle fibers. When the fiber matures, the DMHC is converted to MHC, which is the matured version of that protein, indicating that the muscle fiber has now matured. In this type of analysis, lower DMHC expression reflects greater level of maturity of muscle fibers in regeneration. Thus, lower DMHC expression reflects increased fiber regeneration. In short, the analysis showed that the groups that received exercise interventions, the PRP plus exercise and the exercise alone group, had the least DHMC expression, thus indicating greater regeneration compared to the PRP only group and the two control groups. Now, the next question is, does this translate to greater functional recovery? Although the analysis they conducted for muscle function is highly limited, researchers found that exercise intervention resulted in greater functional recovery as measured by the maximum force output of the injured muscle. So, in conclusion, this study supports the contention that exercise is regenerative medicine, specifically in the context of muscle injuries. And this is because of the loading and thus mechanical stress afforded through exercise therapies. This is stimulatory to regenerative and anabolic processes in muscle, which would improve the overall quality of healing. And this seems to translate to improved late functional recovery. So now that we've covered the science underlying early mobilization, what are the practical guidelines concerning immobilization and mobilization, especially in the acute phase post-injury? Initially, immobilization should be employed to prevent exacerbation of the muscle injury. This aligns with the P, protection part, per police principle, as well as the rest portion of optimal loading. It would be unwise to prematurely mobilize and mechanically stress the injured muscle, as this could widen the wound gap and eventually compromise the quality of healing. With grade 1 strains, immobilization may last for about a full 24 to 48 hours, while grade 2 strains may require immobilization up to 3 days. With grade 3 strains, however, longer immobilization periods would be required due to the avulsion, and thus about 7 days would be required. The reason why we have these periods of immobilization, in accordance to the severity of injury, is to allow for adequate scar tissue formation to occur to provide some structural integrity to the muscle. In other words, we need to give scar tissue formation some time to allow the muscle to be a bit more resilient to tension and thus less susceptible to re-rupturing. Thus, mobilization and optimal loading can be introduced as early as 3 days up to 7 days post-injury within the limits of pain. And of course, loading through manual therapies should progress towards exercise therapies and eventually exercise training back to pre-injury status. And this leads us to part 2 of this series, where we will discuss all subsequent phases of strain management and care. We will also discuss concepts related to prevention, also dubbed as prehab. Also, we will discuss DOMS, delayed onset muscle soreness, and if this is something we need to quote-unquote treat. From here, we will introduce the topic of exercise recovery, which will segue nicely into the subsequent lecture series.